Buenas tardes, good afternoon, bona tarda. It's a pleasure for me to be the host of this liver seminar conference and to introduce Dr. Jonel Trevica, who I think it's the right person for the right title of this conference. So Jonel, to be short in summarizing his lifetime so far, Jonel was trained, educated in Bonn, where he attended medical school, and then he completed internal medicine residency and also gastro at the same time. He spent until 2018 in Bonn in different positions. He had time during this period to also go to Denmark and got a PhD there in the University of Copenhagen. And he holds, I don't know exactly since then, position as an associate professor of the University of Southern Denmark in Odense. For the past 2 years, he moved to Barcelona and to 217 until the end of last year, and he was working with the Cliff Foundation, mainly as a principal investigator of the PREDICT study. He finally went back to Germany, but he didn't go to Bonn, and he changed Bonn for Frankfurt, where he is now currently professor, and he's in charge of the section of translational hepatology. And he's now, trying to build a research place there that we hope will be as successful as it has been so far.
Yeah, dear all, many of you know me already, and I really am not in everything, even though Joan said that I am in everything. But my main interest actually in the last years has been portal hypertension, acute and chronic liver failure, and this is also the future. My future activities will go in the direction acute and chronic liver failure, especially with link to microbiome. Nevertheless, the title "Clinical Implications of Transnational Investigation in Portal Hypertension" is claiming to talk about portal hypertension and mechanisms and how can we translate this into clinics and what has been done so far. And I think that if since you invite me, I will show you some of my data. That does not mean that there are no other data outside, but I just wanted to introduce my work to you, which may know some of it, but maybe not everything. And also I would like to present you some new data which have not been published so far. Okay, these are my disclosures, and I would like to start very basic, very simple. Many of you know this. This is the sinusoid, and indeed there are several cells which are of major interest: the endothelial cells, the hepatic stellate cells, the hepatocytes, the immune cells, and indeed after a chronic liver injury we have inflammation in the liver, which drives the activation of hepatic stellate cell, changes of endothelial cell phenotype, and also of hepatic stellate cell phenotype. We have accumulation of fibrosis, and this fibrosis together with contraction of myofibroblastic hepatic stellate cells, or HSCs, they increase the hepatic resistance. And indeed, this is the first step into the development of clinical significant portal hypertension. And the increase in hepatic resistance leads to an increase in portal pressure, but reflectory also to splanchnic vasodilation. So we have a pooling of the venous blood and arterial blood into the splanchnic region, which in turn increases the cardiac output, which instead of while maintaining the perfusion pressure of different organs, also increase the portal venous inflow due to the vasodilation in splanchnic vessels, and further increases portal pressure to the clinically manifest portal hypertension. So we have two mechanisms which lead to increased portal pressure. On the one side, the inside the liver, so the increased hepatic resistance, and on the other side we have the pooling and the vasodilation in the splanchnic region, which has several reasons how it develops and leading to an increased portal venous inflow. Indeed, the portal pressure is the main driver of complications. It translates directly to the development of varices and also to bleeding. But also when portal hypertension stands for a long time in the patients and we have an increased cardiac output with a severe vasodilation, then the effective blood volume drops, and this leads to a decreased perfusion of important organs, especially of the kidney, which reacts very rapidly to the decrease in effective blood volume, and the perfusion goes down, and we have renal dysfunction with ascites, hepatorenal syndrome, and so on. So the decrease in portal pressure, if we decrease the portal pressure, then we might prevent also decompensation, because we prevent all the consequent causes of it. So what will be the agenda of my talk today? I would like to talk about the non-selective beta blockers. I think this is the best example of translational research and clinical implications of it. I will talk about beta-3 adrenoceptor agonists. Many of you don't know them anymore. They were 10 years ago published by our group and also from Bologna, confirming the results of each other. Of PDE5 inhibitors, you know it only as a potent increasing agent, Viagra, for example. Statins, you know, everybody knows them already. Everybody's talking about statins, and there is a lot of clinical translation and implications with statins. I would like to show you some data on YAG inhibitors, which you might know them, and there are very few first clinical data on that. And then some new, still unpublished data on AT1 blocker combined with neprilysin inhibitors and some HSC-specific targeting. So regarding the non-selective beta blockers, this has been studied a long time ago. And starting again to the cartoon that I showed you before on the development of portal hypertension and complications, you may know that propranolol, one of the key non-selective beta blockers of the first one, was published in 1982 by Didier Lebrec in Paris, showing very nicely that you decrease the cardiac output and also you increase splanchnic resistance by blocking respectively beta-1 adrenoceptor and by blocking beta-2 adrenoceptor. And thereby you decrease the portal venous inflow. However, you don't change the hepatic resistance using propranolol. Later on, carvedilol came also in this condition, and then this has additional effects on the alpha-1 adrenoceptor blocker, which might decrease also a little bit the hepatic resistance and thereby might be more effective. And this was shown very nicely by the group of Thomas Reiberger, and Matthias Mandorfer is also here in the room. So we see that the patients, there were about 30% response to propranolol in the patients who received propranolol on the portal pressure measurement, but carvedilol had a higher increase in response. And indeed, these are all data, but there are also new data in Lancet published showing that the responders have a better outcome than non-responders. You see here patients with response to non-selective beta blockers, they have less bleeding than patients who are non-responders to non-selective beta blockers, as well as they have improved survival compared to the patients who do not respond to non-selective beta blockers. So non-selective beta blockers are the first example showing that we might have a good drug targeting starting from the pathophysiology of portal hypertension, which prevents decompensation, prevents bleeding, and also improves outcome. But there are more than beta-1 and beta-2 adrenoceptors. There are also the beta-3 adrenoceptors. And non-selective beta blockers might block also beta-3 adrenoceptors. So what is the role of beta-3 adrenoceptors? We focused on this beta receptor, and we looked at beta-3 adrenoceptors, and we could demonstrate that they mediate relaxation, they are resistant to desensitization, and they require very high catecholamines. And looking into the human liver, we see that the cirrhotic liver beta-3 adrenoceptor is highly upregulated. And this is mainly in the activated hepatic stellate cells. You see here the hepatocytes, quiescent hepatic stellate cells, or activated hepatic stellate cells. And we have an increase in beta-3 adrenoceptor mRNA in these cells. And if we give a beta-3 adrenoceptor agonist, then we can decrease portal pressure. The major mechanism is through twofold. On the one side, CAMP calcium dependent, and on the other side, calcium independent through Rho kinase. Indeed, we can use beta-3 adrenoceptor on top of beta blockers. So we have a beta-3 agonist together with a non-selective beta blocker like propranolol, and you can see here that the cardiac output remains the same. So we have a decrease in cardiac output after propranolol. We have effect on hepatic resistance, a major effect on hepatic resistance in the combination, and we have a decrease in splanchnic vascular resistance, a slight decrease when we use both. So beta-3 adrenoceptor is also expressed somehow in the extrahepatic tissues. However, the additive effect on portal hypertension was clear here in these experiments, and we could show that the beta-3 adrenoceptor agonist could decrease the portal pressure on top of propranolol. Is this possible to give it in the human? Yes, it is. We have mirabegron from Astellas, it's a beta-3 agonist, and also from Sanofi Aventis, amibegron. Both of them are beta-3 adrenoceptor agonists. So we can combine non-selective beta blockers with beta-3 adrenoceptor agonists. Indeed, non-selective beta blockers have been used for the last 30 years, since '82, and but it has a lot of limitations for their use. One of the limitations is that the beta-3 adrenoceptors might induce impotence in these patients, erectile dysfunction. And indeed, this is Frank from our group, Frank Ushna. He investigated this in cirrhotic patients, and he demonstrated that in cirrhotic patients with severity of liver disease, we have a decrease, or we have an increase in incidence of erectile dysfunction. This is a questionnaire. And also that the use of non-selective beta blockers was an independent predictor of development of erectile dysfunction in these patients. And indeed, as I told you before, phosphodiesterase 5 inhibitors, they have been used in the to increase or to treat erectile dysfunction. And we were looking into phosphodiesterase 5 in the liver and said, okay, could this be also an option for portal pressure, because these are major vasodilators. And we looked into the expression of phosphodiesterase 5 in the liver, and also in combination with NOS2 and NOS3, and we see that they are all upregulated, especially also phosphodiesterase 5 is upregulated in human cirrhosis compared to the non-cirrhotic human liver samples. And looking into BDL model and also CCL4 model in rats, we see the same thing. So we see an upregulation of phosphodiesterase 5 together with NOS2 and NOS3 in this level. So we know that NOS2 and NOS3 are upregulated in cirrhotic liver, however, they are ineffective. And one reason for their ineffectiveness could be also phosphodiesterase 5. Then we further looked into the phosphodiesterase 5 and its cellular distribution. And you see here that the major contributor for phosphodiesterase 5 is the hepatic stellate cells, especially when they are isolated from cirrhotic animals. As you see here, hepatic stellate cells isolated from SHEM animals and from BDL animals, you have an upregulation in phosphodiesterase 5, and this is by 20 times as much as in the endothelial cells. However, also here, if you isolate LSEG from cirrhotic animals, you have an upregulation of phosphodiesterase 5. So our putative mechanism was that indeed hepatic stellate cells, they have phosphodiesterase 5, which induces CGMP and promotes NO effect, more or less, and increases the relaxation through NO, which is produced by NOS in endothelial cells. This is also relevant at hemodynamic level. We investigated the perfusion pressure in isolated livers, and you see here that using phosphodiesterase 5 inhibitors at the different levels, so you have a decrease. I don't know where it is here, because I see only my mouse here, but I don't see it in. Can you see the mouse? No. So okay, maybe you have a pointer. No, there is nothing. But so the upper level is udinafil and L-name, and you see here that you have an increased contraction if you block NO. So the udinafil effect is dependent on NO, and the lower curve in figure 2A is the udinafil alone. It shows that you can relax the hepatic resistance in BDL, and similarly also in CCL4 animals, you can see basically the same thing, that you have udinafil can relax the vascular resistance in the liver. And also in vivo, in BDL and CCL4 animals, if you give udinafil, you have a major decrease of 30% of the portal pressure. And this is additive to propranolol. You see here propranolol can decrease the portal pressure in the second diagram in the middle, in the lower panel, and there, yeah, okay, I can just, I tell you. what you should see. So you see here in D, in the panel D, that we gave first propranolol, and then we have a decrease in portal pressure by 25%. This is what is expected also. And then if you give on top Udenafil, then you have a further increase up to 40%. So you have an additive effect on administration of Udenafil on top of propranolol. And if we can co-administrate this with in the mean arterial pressure, it remains the same. As you see here, there is no major change if you give propranolol together with Udenafil. If you give Udenafil alone, and this is the upper panel on the right side, you see that you have a 25 to 30% decrease of mean arterial pressure. So this could be also another option to combine the non-selective beta blockers, which are already standard of care in these patients, with phosphodiesterase 5 inhibitors like Udenafil. Now the question is, of course, can we improve the erectile dysfunction? And these are experiments also again done by Frank Uschner. And he could stimulate the penile nerve in order to induce erection. And you see here that this is in cirrhotic animals. The erection is also decreased by 31%. And also if you combine propranolol and Udenafil together, then you see that you have an additive effect of the erection, so you can improve quality of life of patients' oriented outcomes, reported outcomes in these patients, if you use the combination of non-selective beta blockers together with Udenafil. So this is only that you should think about it, that not everything is portal pressure, but you are treating patients and you have to improve quality of life in all these patients. So Udenafil is also tested already in cirrhotic patients, and we have the proof of concept study, which unfortunately has been shifted here. But you have a decrease, cumulative decrease on the portal pressure if you give Udenafil in different doses, and also for 7 days. This is a summary. So you have day 0, 70% decrease in portal pressure, day 6, 13% decrease in portal pressure, still significant. However, these patients do not have non-selective beta blockers on top. So if you can improve the effect of non-selective beta blockers, also using Udenafil or other phosphodiesterase 5 inhibitors. Another success story are the statins, and here in Barcelona there have been many studies, also in several groups, also in the group of Joan, and also in the group of Hospital Clinique of Jaime and Juan Carlos Garcia Bagan and Jordi, and also now the study by Peragines, showing that statins have beneficial effects. I would like to just to summarize what has been done up to now, and maybe which are the mechanisms. And indeed, the first thing to treat in patients with chronic liver disease is to treat the underlying cause and cofactors, but this is not always possible. That's why we should treat fibrosis. In order to treat fibrosis, we have to target the activated hepatic cells. This is our philosophy. However, also the LSAC are extremely important to be targeted, and statins is a dual one. I would like to show you some data on hepatic stellate cells. Indeed, what we shown before is that if you inhibit the small GTPases, then you can decrease the effect of Rho-A and also Rho kinase in hepatic stellate cells, and we incubated hepatic stellate cells with atorvastatin, and you see here that the membrane-bound Rho-A is decreased in these cells, and also this leads to a decrease in fibrosis, as you see here in the lower panel after BDL and treated with simvastatin for 1 week after several weeks of bioligation. And this is also not only the effect on the fibrotic mechanisms, but also on the contraction mechanisms, because Rho-A and Rho kinase are major drivers of contraction. And indeed, Rho-A activates Rho kinase, and Rho kinase deactivates myosin light chain phosphatase, which leads to relaxation. And we could show this in vivo in liver samples, as you see here in the left panel, in the lower panel. Myosin phosphorylation was decreased, and then in hepatic stellate cells in vitro, the contraction of the cells was decreased using atorvastatin in increasing dose, and also the basal resistance in vivo in animals receiving atorvastatin was also decreased, and this led to a decrease in portal pressure in these animals without effects on mean arterial pressure. And this has been shown also very nicely here in Barcelona by the group of Jaime Bosch and Juan Abrales in this study, showing that the statin have an effect on the portal pressure, so they decrease majorly portal pressure by about 10%, and this was an additive effect on beta blockers. As you see here on the left panel, on the right panel on the upper diagram, that you see here that the beta blockers, the patients receiving beta blockers had an additive effect on statins. So beta blockers can be supplemented by or can be added to different treatments, for example to beta-3 adrenoceptor agonist or to phosphodiesterase 5 inhibitors, also to statins. This can be a positive effect. And there was a large study, the BLEP study, showing that simvastatin given for a longer period of time, I think it was the observation time was 2 years. The patients after the first bleeding, they showed an improved survival after simvastatin, and the reasons for improved survival could be various. However, the bleeding in these patients was not significantly different in both groups. So it might be that simvastatin has different effects on these patients with liver cirrhosis, and many of these effects are not yet well investigated. However, statins are also not without side effects. As you see here in this in the table, there were severe side effects, and also several of them were related to simvastatin intake, especially rhabdomyolysis in the lower panel, in the lower field, the rhabdomyolysis, and also toxicity to various agents. Even though it were lower numbers, still this is an important point, especially in patients with severe liver dysfunction. And then I would like to show you some data which were presented already in AASLD 2018 from a group of Peragines. This is a multi-center study, a European Union-funded Horizon 2020 study, Liver Hope, which combines simvastatin together with rifaximin. And this is the safety study, which combined different doses of simvastatin. And indeed, the study showed very clearly that the dose of 40 milligrams of simvastatin could be toxic in some of the patients taking it, and it showed an increase in AST, increase in ALT, and also increase in creatine kinase in these patients, which might limit the effects of simvastatin and also might lead to serious severe effects, which led to discontinuation of the drug. So simvastatin, or statins in general, are not the best drug in higher doses, but we have to really select well the patients in order to give the statin to these patients. And importantly, I would like to also to highlight another study which has been recently published from the group of Joan Genesca, showing or combining atorvastatin with NO donor. And indeed, this could be also another approach to limit the toxicity of statins. This NCX6560 showed a decreased effect or mortality, also hepatic toxicity and muscular toxicity rate compared to either atorvastatin or simvastatin, which were pretty much toxic. This is an animal study. However, it shows very clearly that the dose given, it is much higher, with the same efficacy in terms of improving portal pressure, in terms of improving the fibrosis, but it has much lower toxicity rates. So we should think of alternative statins, and also we should be very careful on the drugs, on the dose which we use. Another drug which is already in rheumatoid arthritis and also in other diseases are the JAK inhibitors. JAK inhibitors have been used especially in several occasions to treat immune-mediated diseases. However, we were looking downstream of the AT1 receptor for different pathways, and there were published recently that not only the overexpressing of renin leads to an increased fibrosis and also portal hypertension, but also the JAK2 mediated RhoA Rho kinase activation was a crucial mediator. And I would like to show you some of the data presented by or published by our group. On the one side, we could demonstrate that the Janus kinase 2 activation was increased in different models of liver disease in mice and rats. So we tried 3 models in rats and 2 models in mice. Everywhere it was highly upregulated. Robert Schierwagen and Michael Agranzo did this work and published 2014. And indeed, we also see that the Janus kinase 2 activation, especially the phosphorylation of Janus kinase 2 in a specific site, was highly upregulated in hepatic cells after their activation, and not in the hepatocytes or other cells. And indeed, We also investigated human samples, as you see here. Phosphorylated Janus kinase 2 and alpha-SMA, they have a co-localization in the human liver tissues from cirrhotic patients, and they correlated with the development of spontaneous bacterial peritonitis, ascites, variceal bleeding, and also esophageal varices, so complications of portal hypertension. So there is a role of Janus kinase 2 expression and activation in liver cirrhosis. And if we blunt Janus kinase 2 using inhibitor, which is AG490, for example, in this case, we could also decrease fibrosis. And this was confirmed independently by another group published 1 year later. And this was basically through the activation of hepatic cells. As you can see here, if you overexpress Janus kinase 2, you can also increase the activation of hepatic cells. But it has also an effect on the contraction. You see that the contraction of primary rat hepatic stellate cells dose-dependently is decreased in the first upper panel. As you see here, there is a decrease dose-dependently, and also if we give it in vivo in the animals, we can decrease the hepatic vascular resistance, and also in vivo the portal pressure is decreased in the animals. And this was also again independently confirmed by other groups. Even on top, they showed that the propranolol together, if you compare it, or if you combine it with non-selective beta blockers, you can improve the efficacy on the portal pressure. And there are also several options in humans, especially ruxolitinib. Jakavi is already obtainable, and there is already in clinical use in several indications. And there are many others in the pipeline. I think pacritinib is one of the, it's JAK2 specific one, and it's one which we are planning to continue in the future also in the clinical setting. Nevertheless, we had the option to use ruxolitinib in one patient who had an indication. He had a bone marrow transplantation when he was 2, and at that time when he presented to us, he was already 23 and had a liver cirrhosis with portal hypertension, and he was on Jakavi. So we measured the portal pressure before and also after Jakavi, and we could observe that 30 minutes after taking 5 milligrams of Jakavi, of ruxolitinib, the portal pressure was decreased by 5 millimeters of mercury, so it was really a significant decrease of 45% in HVPG, which shows that really we have a drug which we can use in the future. And there was another report from Singapore where they showed that there was a patient with again not cirrhosis, but he has portal hypertension and had Jakavi, and before of that he had HVPG 13 millimeters of mercury, and 42 months after Jakavi the HVPG was only 4. So it seems that Janus kinase 2 inhibitor seems to be a very potent blocker of fibrosis and also of portal hypertension, which can be further explored. Another enzyme which is very important in the development of fibrosis and also especially involved in the shortcut of angiotensin 1 to angiotensin 1 to 7. So the bad guy is angiotensin 2, which activates the AT1 receptor. However, angiotensin 1 can be directly converted to angiotensin 1 to 7, which is the good guy, and which induces the MAS receptor and mediates resolution of fibrosis and also decrease in pressure, also relaxation. And this is neprilysin. Neprilysin seems to be upregulated in different models of liver cirrhosis. You see here in mice, we have BDL, CCL4, you have an increased neprilysin in the liver. You have in the high-fat diet and also MCD diet, you have an increase of neprilysin expression. And if you see on the right panel, these are patients' data showing neprilysin mRNA expression together, a correlation with collagen 1 expression in the livers and of NASH, and you have a strong correlation between collagen 1 expression and neprilysin RNA expression. These are data in collaboration with Peter Dietrich and Klaus Hellerbrand from Erlangen. We had the chance to use neprilysin knockout mice, and you see here after the induction of fibrosis using CCL4 but also using BDL, we see the same thing. We see a decrease in fibrosis, and this was shown in decrease in serous red staining and also hydroxyproline. But interestingly, and this was a bit unexpected, neprilysin knockout mice, they show an increased alpha-SMA staining, especially upon liver injury. And this was, and also an increased portal pressure. So it was a little bit, we were a little bit puzzling. What is the reason why neprilysin knockout mice show more alpha-SMA staining and also show more portal pressure? We looked further into the into this matter, and we observed that neprilysin, or we found out that neprilysin is not only metabolizing angiotensin 1 to angiotensin 7, but also it is metabolizing NPY. NPY is neuropeptide Y, which is known to be a co-transmitter of contraction and also an important mediator of contraction in different settings. And indeed, if we look into the liver of these animals, we see that the expression of renin and ACE in neprilysin knockout mice is highly upregulated, and also we have an upregulation, or we have more NPY in the liver of these animals, either in controls but also in deceased animals. So NPY might be the key, and we looked further into this. And then what is NPY? Maybe I can just recall you, in 2011, together with the group of Rainer Wiest, we published this paper where we showed that NPY administered in the rats with cirrhosis decreases portal pressure, and this is due to a decrease in portal tributary blood flow, so the portal venous inflow, and this was due to an increase in splanchnic vascular resistance. And we had also beneficial effects outside the liver, but in the liver there were little data looking at it. What happens in the patients? Do we have the same situation? Indeed, we have the same situation. NPY seems to be higher in the portal vein compared to the hepatic vein. These are samples taken at TIPS implantation in patients with severe portal hypertension, and this suggests that NPY comes from the splanchnic circulation, goes into the liver, and might have different effects in the liver. And looking again into this matter, we looked into which are the cells producing neprilysin, and we observed that only hepatic stellate cells were the one who had the neprilysin mRNA levels, and especially upon induction of liver injury using BDL, we see a strong upregulation of neprilysin. And looking into NPY, we observed that also NPY was mainly in the fetal calf serum, so it was not produced by hepatic stellate cells or fibroblasts. So we do not have an autoregulation, but this is something that coming from outside even the liver or outside the hepatic stellate cells into the stellate cells, and inducing the effect of decreasing fibrosis and increasing contraction. Looking into the in data in silico, we observed that neprilysin can hydrolyze NPY into different length. On the one side, 21 to 36 peptides, and on the other side, 31 to 36 peptides. And these two peptides were very nicely fitting into the NPY1 receptor and stimulating the NPY1 receptor. And that's why we observed also the CAMP, and the CAMP induction was due to the cleaved NPY. So the NPY, which was cleaved externally, could induce in hepatic stellate cells which were deficient for NAP an increase in CAMP and stimulate the receptor, the NPY receptor. So the whole idea is that indeed the cleaved NPY induces collagen, as you see here in the middle bar, induces collagen expression, while all the other combinations with full length NPY or the receptor blockage do not increase contraction. So how can we translate this into the clinics? Indeed, we combine the neprilysin knockout together with losartan and or with captopril. So we blocked the renin angiotensin system using either AT1 receptor blocker or ACE inhibitors, and you see that the portal pressure and also fibrosis was decreased additionally to neprilysin deficiency if we use both agents independently of each other. And we did this also in purpose with the translational objective, because indeed in humans there are already the ARNI, so it's from Novartis. They have Entresto. It's one drug which is combining AT1 receptor blockers and NAP inhibitor, and they have shown already that they have a benefit in they improve survival in patients with heart failure. And also here you see the same thing in both studies. The paradigm studies published in New England Journal of Medicine and also in Circulation showed that you have an additional effect on ACE inhibitors using neprilysin inhibitors on top of the either ACE or AT1 receptor blockers. However, the question is also why do we have to use such cocktails? Can we just not use one drug going a little bit more further or down and decrease the pressure? Indeed, it has been shown that AT1 receptor blockers, they are not well tolerated, so we cannot use one drug. We need a combination of drugs. And indeed, they on the left side, you see a study from Bonn, from our group in Bonn. And on the right side, you see a study from our laboratory using Rho kinase inhibitors. So either the AT1 receptor blockers or Rho kinase inhibitors, they decrease portal pressure. However, they have disastrous effects in the systemic circulation. So it's not so easy to do that. So how can we do it? We can go directly into the hepatic stellate cells, which are the key cells producing fibrosis and also contraction and increasing portal pressure. And you see here studies in a collaboration with Klaus Pölsler from Groningen, which were published by Sabine Klein from our group, and showing that you can use you can combine Rho kinase inhibitors to carriers which go directly to the hepatic stellate cells when they are activated using a carrier which contains human serum albumin and mannose-6-phosphate rests. And this is linked to Rho kinase inhibitor. This is uptaken by these activated hepatic stellate cells and decrease portal pressure without systemic effects. But we saw some extra hepatic effects. We saw a decrease in cardiac output indeed, and this was probably due to the pharmacology of this carrier, because the carrier was not fully internalized, and it could be that there is some heterogeneization outside the cell. So the Rho kinase inhibitor might spill over into the heart and decreases cardiac output by 25 and also by 80%. And this was not fully explained by the decrease in portal pressure, which might be the reason for improved hyperdynamic circulation. That's why we moved to another carrier, and the carrier was a Rho kinase inhibitor binded to a B peptide, which recognizes the PDGF beta receptor. And indeed, you see on the upper panel, you see a nice merge with the human serum albumin in rats, given in rats, in the CCL4 rats, and with desmin, that we can confirm that this was uptaken by the hepatic stellate cells, and later also that we can abolish contraction as shown by the myosin light chain phosphatase, so we can inhibit Rho kinase activity in these animals by this approach using Rho kinase inhibitor linked to the B-cyclic peptide targeting the PDGF beta receptor. This work was done also again by Sabine Klein and Fernando Magdaleno, who unfortunately is not anymore in my group. And indeed, they showed also that we have a decrease in fibrogenesis, as you see here, a decrease in mRNA of collagen 1 and PDGF beta receptor, and also a decrease in portal pressure, which was dose dependent and also time dependent. We had one single shot in these animals, and we could decrease the portal pressure by 33% and the hepatic vascular resistance by 52%. And this was repeated also in CCL4 animals, and the same without any mean arterial pressure difference, as shown in the next slide. And also what we observed, which was very interesting, was that we observed an increase in renal blood flow in these animals. So even though this is not so specific, or it was not extremely specific for hepatic stellate cells, this drug exerted some extrahepatic effect which were beneficial. So we did not see any effect on the extrahepatic systemic circulation, but we see a binding to the PDGF receptor in the kidney, which we know that in cirrhosis it is upregulated, and also we saw improved perfusion of the kidney in these animals 3 hours after injection of the drug. So this is also, I'm coming to the summary of my talk. So I hope that I could convince you that we have several drugs, and especially the combination of the drugs could have some clinical translation and also implication. And many of these drugs are already in the clinic. Some of them are still not yet approved for the indication. However, we are free to use them. And some of them, of course, have to be further developed in order to get into the clinics. So the non-selective beta blockers, they decrease the cardiac output and improve splanchnic vasodilation, and thereby they decrease portal pressure by decreasing the portal venous inflow. Especially in combination with beta-3 adrenoceptors, which also work in the liver, inside the liver. I think this is a very nice combination, which decreases furthermore the portal pressure and improves the systemic hemodynamics in the animals, and I think also in the patients will be the same case. Also, the combination of non-selective beta blockers with phosphodiesterase 5 inhibitors could be also another important improvement, not only because of the additive effect on the portal pressure, but also because of the patient's reported outcomes, like erectile dysfunction, which nobody talks about it. It's taboo, but I think this is an important limitation in use of non-selective beta blockers, especially in child A cirrhotic patients. Statins, I think everybody talks statins at the moment. There are every month there is some review or some opinion about statins, and the majority of them are positive. Still, we have to be careful. The Liver Hope study will also show whether we can prevent acute and chronic liver failure in combination with rifaximin in this setting. However, statins is a very nice drug that can be given to patients who are stable and to patients who have a severe portal hypertension. Janus kinase 2 inhibitors, I think still there is an important indication for this drug, especially in the setting of more specific Janus kinase 2 inhibitors. Maybe ruxolitinib is not the best one, but pancreatinib could be a very good candidate. AT1 receptor blockers and neprilysin inhibitors, the combination, so the ARNI, they have important effects in the liver and also extrahepatic. They have a strong antifibrotic effect, as we saw before, and also the combination might be a successful one for patients with portal hypertension. And of course, hepatic cell specific targeting. It is very good, especially if we use PDGF-beta as a marker, because in this case we can improve both the hemodynamics in the liver and also in the kidney, which is one of the main reasons for mortality also in patients with liver cirrhosis. I would like to thank my group. This is my group since Joan told you that I moved from Bonn to Frankfurt. Some of them could not move with me, especially some technicians, which is Gudrun Hack and Silke Bellinghausen. We are missing them very much. Max Broll, I didn't present his work yet, but he is one of our students who is going for some short time in Bern and coming back to Frankfurt, I hope, next year. Sabine and Robert and Frank moved with me. They are together with me in Frankfurt. Sophia is from Porto. She was a student at the time in my lab and moved back to Porto. And Fernando Magdaleno moved to nephrology because he liked so much the kidney effects of our drug, and also stayed in Bonn. So I would like to thank all the collaborators involved. There are many more, but these are the people who were involved in the work I presented, and also all the fundings, and you for the attention, and happy to take any questions. Obviously, I don't have the answer, but I think that first, non-selective beta blockers was a very helpful finding. It is 30 years ago, of course, and I mean we saw also the paper in Lancet showing very clearly a benefit of non-selective beta blockers in prevention of decompensation. And I think that non-selective beta blockers needs to be in the armatorium of treating patients with complications of portal hypertension or also with portal hypertension. And that's why I also focus this in that time, because I think that we do not have much other drugs targeting the extrahepatic compartment so beneficially like the non-selective beta blockers. So I think that the non-selective beta blockers are already well accepted. What we should do is go more into the liver, and we should go more specifically into the liver, or extend our focus to other organs like kidney, for example, because we know that this is one major kidney dysfunction is a major source of complications and also of mortality in our patients. That's why I highlighted especially the combination. I think that the combination between drugs which might have some systemic effects with non-selective beta blockers could be a way to prevent this. On the other side, statins are very good. Have been shown very nicely that they are improving the portal pressure, are improving survival. However, we have been giving statins for, I don't know, 40 years or 50 years in the field, and of course always the patients with severe chronic with severe liver disease were excluded from these studies. Still, we did not see a on-off effect of statins. So I think there might be some effect, but probably not the major. So I think still that the combination statins with non-selective beta blockers or statins with rifaximin, as in the case of Liver Hope, could be really a nice way to move forward, or non-selective beta blockers with phosphodiesterase 5 inhibitors. And the problem of the field is that the drugs are already there. So they are all approved. we can use them off-label. So maybe what we need is such a platform where we can combine drugs and studies and patients' experiences and so on, and to test easier different drugs in a more smooth way. And for sure, everybody is now working for personalized medicine. I think that also targeting into specific cells, it's an important point, either to endothelial cells or hepatic stellate cells, using the right targets and using the right carriers and also the right vehicles to bring the drugs there. I think this is the future, but I think we are not there yet in terms of clinical research. So this would be my answer, very complicated.
Thank you.
Yeah, this is a very good question. Maybe other people, experts in statins in the room, can answer this. I can tell you our experience. We try to bypass the effects of statins in order to restore the effect of statins using furanolate pyrophosphate and also granule pyrophosphate, and we failed actually. So I think that the statins effects are much more are much more complicated than what we think. So there are so many pathways which are involved in the statins effect. We also investigated hedgehog signaling, and we found there an effect. And if you look in different cells, you find different effects. So I think that the statins are the typical black box result. You know, you put something on top, and then you see, and then you measure NO, and everybody was measuring NO, and then saying, okay, oh, this is the right substance. We take this substance and we use it in the clinical study. So I think the question is, we have it already. So should we work on the mechanisms of statins, or should we just use statins in the clinical studies? I think we can, for the clinics, I think it's easier to use statins in the clinical studies, and there are so many studies out there, but as I told you, in our hands, we could not reproduce the simple effects of statins with regard to the isoprenylation of different proteins, because we restored this and we could not find any. Yeah, I think there were, I don't know, 20 years ago, there were several studies with TGF-beta inhibitors, and they showed that they had some increased mortality. So TGF-beta, I think it is crucially involved in mediator of fibrosis, but you cannot live without TGF-beta. This was the problem. So if you inhibit TGF-beta, then the animals, they had an increased mortality. So I think these were data, I don't know, maybe Mercedes, you remember, it was from either from Scott Friedman or from Detlef Schupan, showing very, very clearly that the pure TGF-beta inhibitors didn't work well. So they had a strong antifibrotic effect, but they did not survive. So the animals.
Thank you.
So it seems that TGF-beta is a key, or it's a very important survival mediator also for different cells. And I think that TGF-beta, at least in my experience, we use it only as a readout with just more or less fibrosis or fibrogenic potential. But to target directly TGF-beta after these experiences, I think there were many people left this behind. Yeah. Oh yeah, this is a very good question. It's also, for sure, it is a philosophic one, and if I may, then I will also further philosophy. I think that yes, that there are different mechanisms leading to portal hypertension. The question is, which is the portal hypertension which leads to complications? Because we see also many people who have portal hypertension with HVPG defined as HVPG upon more than 10 millimeters of mercury. However, many of these people, they will never develop any complications. So the reason to treat these people would be only the presence of portal hypertension. And if you don't check the portal hypertension, or if you don't measure the pressure invasively, then you will never know that this patient has clinical significant portal hypertension. So I don't know at So how we should go on this? There are many reports that patients with steatosis, plain steatosis, and also animal models of Western diet or high-fat diet in rats, published also by Sven Franke, but I think there are also several data from Vaida Blon from the group of John Ginesca and Salva Agustin, showing very nicely that they have an increased portal pressure only having severe steatosis and also having NASH, but the mechanisms might be different. So I think that it's very important to elaborate on the mechanisms which induce the portal hypertension. On the other side, NASH patients, if they don't have NASH, severe fibrosis in NASH patients usually don't die of chronic related diseases. So usually they die of cardiovascular disease or diabetes or long-term effects of diabetes. So this is a very important question what you ask. So where should we treat when? So I think we have there are many things that are changing now. The scenarios are changing at the present. So we have NASH, emerging disease. We have portal hypertension, presence of portal hypertension in NASH patients with probably different mechanisms. However, we don't know how clinically relevant is this, and so these are several things, and we have models. I think that there are some models out there that we can observe portal hypertension in this, that we can reproduce the portal hypertension in NASH. So I think this is a very important question, and indeed, a combination of beta blockers, it depends very much on what are the comorbidities of the patient. So for sure, I would try to give statins with non-selective beta blockers, and then dependent on how the patient is, whether he's a child A patient, I could also consider to give phosphodiesterase 5 inhibitors or beta-3 adrenoceptors. However, these are not available still, at least in Germany. We have some problems with that for the market because they are not produced anymore, at least from from Sanofi and from Aventis Sanofi, but there are some from Astellas. And then in the further or with more severe patients, I would also try to go with Janus kinase 2 inhibitors, because Janus kinase 2 inhibitors have a very strong anti-portal hypertensive effect and also very strong antifibrotic effect. But we have to consider some side effects. So depending on the stage of disease, so patients with, for example, with varices, which are defined as that they need treatment either with child B or child C cirrhosis and varices, I would go for statins and not selective beta blockers. But patients with child A, large varices, I would consider to give beta blockers and phosphodiesterase 5 inhibitors. So this would be my choice, actually. Yeah, not consistently. There are some studies, and indeed with Dominik Wolf from Innsbruck, he was before in Bonn also, and now he moved to Innsbruck. We were looking into it, and we see a considerable effect of Janus kinase 2 inhibitors, because in patients with myelofibrosis, it has an indication, it has a label for it, and we see a beneficial effect on the portal pressure. However, I slightly disagree with you, because ruxolitinib, so the Janus kinase inhibitor, has infection complications because of its Janus kinase 1 effects. So this is still a dirty drug. So ruxolitinib has Janus kinase 1 effects, it has TYK1 effects, and other kinase inhibitor effects, and not only specifically for Janus kinase 2. So there are drugs which are more specific, like pancreatinib, which are more specific for Janus kinase 2, and actually we are testing this with a company to target them to the liver, in order to also decrease the myeloid effects, but also to have a greater liver-centric effect. But this is, on my opinion, Janus kinase 2 more specific inhibition would be the answer to this increased risk of infection. We had several patients with portal vein thrombosis on Janus kinase 2 inhibitors that we had to discontinue them for infections. And the second one, which is not yet really published now, but they have metabolic syndrome. They develop a lot of fat in the belly, and they obesity, especially abdominal obesity, these patients using ruxolitinib, so Janus kinase 1, 2, and TYK1 inhibitors combination. So this is really a clinical problem. So all companies are moving now to more specific inhibitors.
So if there are no more questions, thank you very much for your talk. Thank you very much all for coming. Thank you.